Okay, let's give him a warm welcome and invite him to the stage. Dr. Richard Pan.
Thank you.
Thank you.
Thank you.
Appreciate you being here.
Sure. Thank you, Nene.
Let me, we're going to take your questions here from the audience as well, but let me just ask you to start us off. What are you watching in healthcare today? What are you spending your mental energy?
Well, actually, I appreciate the opening video because certainly healthcare is something of great interest to many people. So when you think about when Governor Newsom was running for governor, one of his signature things he ran on was healthcare, right? And he talked about single payer as being one of the signature issues. After he got elected, there was a poll done by the PPIC because people pointed out, well, he made a lot of different promises or commitments when he was running. Which one was the most important to the people of California? And number one was healthcare. Number one was healthcare. And then, of course, as you saw in the montage that we just saw earlier, it's a major issue in the presidential election as well. So you see all the different candidates talking about healthcare, different angles about it. You hear about Medicare for all. You hear about people talking about public option, building on the ACA. So clearly healthcare is a major issue. Now when we think about what's happened here in California, of course we fully embraced the Affordable Care Act under Governor Brown. And I think that's something that you can't take for granted. You can't just say, well, the Dems were in control, we just go ahead and do this. I mean, there was a lot of back and forth about, is this something that's going to be sustainable? Is this something we're going to be able to afford in the state? After all, we just came out of a large recession at the time when we implemented the ACA. We had a $28 billion deficit when Governor Brown first came into office. So, thinking about the future fiscal stability of the state, but I think what we recognize is that we need to go all in. And actually that if we were going to control our healthcare future, including the fact that the state is funding healthcare for a good portion of our population, think about Medi-Cal, it's a third of all Californians are in our Medi-Cal program, are covered by our Medi-Cal program. And then you want to put on top CalPERS and other types of state-funded and federally funded healthcare programs. Really, that's something that's very important for the state as we're moving forward. And so after Governor Newsom got elected, and we looked at how do we build on what we've done with the ACA, one of the things we did recognize is that, unfortunately, under the Trump administration, there were efforts at the federal level, not just to repeal the ACA, which was unsuccessful under the Republican Congress, but actually to try to undermine the health insurance market, right? So essentially zeroing out the penalty for the individual mandate. By the way, the individual mandate was something that conservative think tanks had actually argued for, because in order to be sure you actually had a working health insurance market, you need to basically require people to participate in the market. Otherwise, you'd have too much self-selection of healthy people dropping out and sick people, being concentrated. And so in fact, that idea of an individual mandate actually came from conservative thinkers who said, this is the only way we can make the market work. So it's kind of ironic that the Trump administration decided and the Republican Congress decided to zero out the individual mandate, and leading to actually a decline in people being enrolled in health insurance coverage. The other thing that we also looked at, we said, well, look, if we're going to require people to have health insurance, we need to help people buy it, right? We need to make it more affordable. In fact, there were actions, again, taken by the federal government, the Trump administration, to actually decrease some of the subsidies that would be provided to people. So we said, as a state, we're going to put subsidies in, and in fact even build and expand on that. So for example, under the original ACA, if you were past 400% of the federal poverty level, you were essentially on your own. So we're putting in subsidies to go all the way up to 600 of the federal poverty level. Now, of course, California being a high expense state, making 600% of the federal poverty level is not quite the same as, let's say, if you were in some other part of the country. So that's why we knew that we had to step in and try to take care of that cliff. And in fact, that's what we accomplished in this past year's budget. Interesting enough, how did the market respond? Well, health insurance premiums on average, in covered California, actually increased less than 1%. Think about that. Insurance premiums increasing less than 1%, all right? That's a pretty rare occurrence. Usually you're talking about what percentage over the GDP increase. This is less than the GDP increase, all right? So, I mean, that clearly sent the positive signal. Of course, we're in open enrollment right now, so we'll see what the actual enrollment figures are. But certainly, I think as all the actuaries and all the plans were working it out, they said, okay, these are important steps to try to actually be sure that we have a functioning healthcare market here in California, as well as actually containing premium costs for Californians. So I think that's, again, a big success. We, of course, also expanded access by Governor Newsom proposed to cover undocumented from up to age 26. The Senate actually proposed going even farther than that. That was not accepted in this year's budget, but certainly there's continued work on expanding access. But I think on the other side that we also need to talk about is issues around cost and quality, right? So certainly healthcare costs are a big issue. We had a lot of discussion about, well, how much should people pay for healthcare? We see stories about, quote, outrageous bills and pharmaceutical prices and so forth. And there were bills talking about, well, what should we do about, generics? Or what happens when someone tries to leverage the insurance pool using, nonprofit entities that are subsidizing insurance? And is that something that should be acceptable or not, and a variety of other issues. So certainly those are going to be ongoing issues. But I think the other thing that we did in the state Senate and the health committee is we also said, well, we need to look at how do we move more toward creating incentives in the healthcare marketplace for people to innovate around taking care of people with chronic conditions, right? So when we think about where we spend our healthcare dollar, well, the healthiest 50% basically spend about 3 to 3.5% of the healthcare dollar. That's why all the health plans want them. The sickest 10% spends 2/3, the sickest 5% spends half. So even if we reduced healthcare spending in the healthiest 50% by 1/3, we'd only have a 1% savings. But we can save even 10%, let's say 10%, even 5%. We said 5%, reduced 5% by only 5%, the healthcare spending of the sickest 10%. That's a 3% reduction. That pays for all the healthiest 50%. So, so we need to think about, well, then where are the incentives for people to take care of people who are at that end of the spending? And when we start thinking about that, we have to think a little bit about, well, what kind of incentives do we have currently in the marketplace when it comes to risk-bearing organizations like health plans or medical groups or health systems that bear risk? And I think part of the challenge is that, in order to survive, you have to look at essentially your risk profile, right? And so even though we put in all these rules in the ACA around trying to prevent people from doing essentially cherry picking, right? So standardized benefits, geographic essentially ratings for premiums, some age change, but basically capped at for younger and older, but basically, but certainly no pre-existing conditions. We also know that doesn't necessarily lead to innovation in better chronic disease care. So let's put it this way. If you're a health plan and you provide the best possible quality care for diabetes, all right, that diabetic patient will still cost you more than a healthy patient, even if you do the best possible job. And so the challenge is that can you innovate when the best you can do is actually reduce your costs, but not actually make a margin on patients who have chronic diseases? And in fact, we might want to think about that particular incentive or disincentive to taking on chronic disease. The other challenge, of course, for many health plans is that oftentimes, of course, you sign up for 1 year. So if you make an investment now, what happens in the longitude, if you can't recover the savings? But so we need to think about some of this inherent incentive structure. So I know there's a lot of talk about value-based payment. We have actually put in money for value-based payment in the Medi-Cal program. I think we had our informational hearing to talk about what can we do on the commercial space, and then also how can we align them, right? Because if you're a physician or other provider, you have a certain percentage of patients from one payer, you have another percentage in the other payer, but in order to make sense for you to change the way you do things, you kind of have to have enough of all the different payers that makes sense for you to make the change, right? So you're going to make a whole change in your practice for somebody who's paying for like a third of your patients. may not be enough. Maybe if we can line 60% or 75% of the payers, then that makes a sense to say, okay, we're going to change the way we actually do things in our practice, in our system. And so how do we get to that point? So sometimes people ask me, so, well, how do I know health reform is successful? And so, some things we can talk about is, we got, do we achieve universal coverage? Do we have anyone who's left behind? But I think one of the things that we should be looking at is that when I see health plans or risk-bearing organizations, groups saying, if you have a chronic disease, I want you in my plan, okay? Like, if you have diabetes, sign up. Here's the number. Anyone see that? Okay, right? All right. So if people are saying, look, I want people with chronic diseases because what happens is that I know that if they sign up for my plan, I can take really good care of them and I can be successful. We're a capitalist society. It means make some money. All right. And when I say make some money, it's not just about money that I'm going to stick in my pocket or give it to my shareholders or something like that. It's about money to reinvest in the next cycle of improvement. Right? If we're going to get this, what I call a virtuous cycle of continuous improvement, there has to be resources at the end of the last improvement to reinvest in the next improvement. And that's one of the things we're missing in terms of trying to manage people with chronic diseases. So there's a lot of great people out there. We have foundations, we have health plans who are doing things, oftentimes one-off things, but in order to sustain this, you have to create an incentive structure that actually allows you to basically have some margin in taking care of people who have complex needs. That way you'll continually figure out how do we continue to invest, put the IT infrastructure, all the other stuff you need to do to make it happen, right? So that's one of the things that I think that often is missing from the discussion. How do we go about trying to, as I'm in government, so as government, create the sort of the incentive structure, the infrastructure for that, and then allow all the plans and the providers and so forth to innovate, and then if they're successful in doing that, be able to realize enough of a return that they're going to continue to innovate and improve. And so that's how we take the sickest, the people at the far end, the 10%, and reduce their cost by 3%, 5%, 10%. Actually, some of the ACOs have, and Medicare, where they've actually concentrated, figure out, I've heard they've had reductions like 10, 20, 25% in spending. So how do we create an incentive structure that allows people to actually want to innovate to do that kind of work? Because that's where we're really going to save money, right? Because that's where the money goes, and so we need to think about that. Now, we hear a lot of discussion about Medicare for all. We had single payer before in California, and one of the things though I try to point out though is that here in California in our Medi-Cal program. That's a single payer, it's a state-funded program, right? State federal, right? It's government-funded healthcare, right? And so when we think about, okay, so what are we doing as a state to make Medi-Cal work, right? Because that is our single-payer program, right? For a third of all, by the way, I'm a pediatrician, so half of all kids, by the way, half of all obstetrical deliveries are under Medi-Cal, and then a third of all Californians. So we got to think about, okay, well, how can Medi-Cal demonstrate that it can work? And I would make note that Medi-Cal itself, the state has decided over the last several decades that the state didn't want to directly run this health program, right? So in the old days, you're a doctor, you saw a Medi-Cal patient, you sent the bill to Medi-Cal. Sometimes the Medi-Cal made you fill a TAR out. You got paid a fee, right? They had some fee schedule or something like that. Now you sign up for a health plan, and the health plan has a contract with Medi-Cal, with the state. So it's interesting that in our own single-payer healthcare system, we've chosen to then turn to health plans to actually administer the program. Now, what does that mean? Well, so the question is what can we do as a state to demonstrate that we can try to improve quality, improve access through our Medi-Cal program. We just had a hearing. We had a couple of auditor reports that showed that, unfortunately, less than half of all our children are getting their well child care visits in Medi-Cal. That's not too good. We know that in rural communities, people are having to travel far distances for specialty care. And then, of course, I know we're here in San Diego, and I'm in Sacramento. We're the two GMC counties in the whole state. And so certainly in Sacramento, we've had a lot of discussions about improving GMC, and I'm starting to hear from many of you here in San Diego that you want to improve GMC. And whether we want to actually improve GMC or blow it up or whatever, certainly that's, I think, something we need to have a conversation about. Where should Medi-Cal go for both not only the GMC counties? I mean, we heard also from rural counties that said that it's not really working for them in our last hearing. So where should we take our Medi-Cal program? And I think that we're hearing all this discussion about Medicare for all, and we had a discussion here in the state about single payer. One of the things we should really be looking at is how do we make our Medi-Cal program work? And being sure that is our sort of our state single payer program. Is it working the way it should be? And what's the accountability in that program? So I could keep going on, but I'm going to go ahead and maybe let you ask some questions, and I'll answer some questions, and we'll go from there.
Yeah.
How's that?
I was, by the way, he won't answer every question with that length. We knew that he was going to take the floor for quite a few minutes there, so that was good stuff. And I will say, I was like, oh, I want to ask about this. I want to ask about that. I had 5 or 6 things, and since you ended with GMC, we'll start there. The rumor is, I hear from friends in Sacramento that you are actively engaged in thinking about GMC in Sacramento and have been trying to think through with local stakeholders there in Sacramento County how to redesign GMC there. I want to talk about how that thinking might apply to San Diego, but first, why don't you tell us, what does that look like in the Sacramento context? What are those conversations looking like? What are the problems that you're trying to solve, and what is the goal you're trying to get to?
Yeah. So as a physician who practiced for 12 years in Sacramento, as a pediatrician who mainly took care of Medi-Cal patients, I think I personally was very frustrated with GMC, and I know many of my colleagues in the medical community were. But not only that, also lots of other, clinics are frustrated, advocacy groups are frustrated, and because there's tremendous fragmentation, there's no oversight over the Medi-Cal. I think one of the things that actually was a driving force was Sacramento County. Actually, there was a coalition that came together to try to address health disparities, particularly around Black infant mortality, right? So there was a big disparity there, as well as maternal outcomes. And so they put together a coalition and certainly made significant progress on that. But when you think about the fact that the Medi-Cal program actually provides coverage for, well, let's say half of all the children and obstetrical deliveries, and of course, since most of the disparities are happening in lower income, we're talking about even more than just half, right? They were not at the table, right? So wait a minute, we have a lot of money that's flowing to provide care that's supposed to address these very issues, yet they were not at the table. And why weren't they at the table? Because there was no oversight entity over the GMC program, right? I mean, Medi-Cal GMC is a bunch of plans that have contract with the state for Sacramento County. There's no accountability to the county. There's no input for our local priorities. There's no data that we, were getting. I mean, there was some data, but I mean, so I think people realize that, well, not only is it dysfunctional, it can't even help us with our major, public health priorities in the county that we've identified. And so what the stakeholder meetings have basically, and it's still ongoing, we've talked about is that we need much more local input. Now, I know here in San Diego, we sort of look at you in Sacramento and go, oh, we wish we could be more like San Diego. Because I think in San Diego, there are provisions in law for more local input. But I think, as I'm hearing from people in San Diego, there's even more we need to be doing in that regard. And so I actually look forward to hearing from people people in San Diego and thinking about, let's put it this way. You may decide you don't want GMC altogether, and that's also a potential conversation in Sacramento. But if we are having GMC, and then we also have these 2 planned things in rural communities, right, as well, so they're kind of quasi-GMC, we might have a conversation about exactly what is the role of, how should those Medi-Cal programs be administered, and what kind of, how do we be sure that there's more local, not just input, but also engagement around these plans. And we certainly heard that in our last hearing when it came to many of the rural counties.
Yeah. So I think, this is my own kind of thought on this, and I'll throw it out there as a premise and you can respond.
Sure.
It seems to me that if you want to make investments in mental health so that people will better manage chronic health conditions, if you want to address social issues so that people will better be able to manage their mental health, which will then save money on the physical health. If you want to do these things that we're talking about doing, the investments you make today will not often bear fruit for some period of time. So to be sustainable, it's back to your point of a virtuous cycle, right?
Yes.
You need to have some longitudinal, some longevity of the risk-bearing entity. And an investment, it seems to me, an investment made by one entity in a person needs to have some sideboards within reason to maintain that person as a beneficiary for some period of time to capture the return on investment. Now, not everything in healthcare should be about return on investment, but we're in a capitalist society and that's how it works. Doesn't that lead to one long-term risk-bearing entity for a healthcare community? Whether that's Medi-Cal or otherwise, I mean, hopefully if we keep people healthy and safe, they find jobs that take them off Medi-Cal and expand into other places. Yeah. So we also need to have longevity in this risk-bearing corridor that maybe expands beyond the line of business. I mean, pretty soon I feel like I'm talking about a single payer model, but really I'm just talking about trying to make it sustainable. And what are your thoughts on that premise I've thrown out?
So I think that, so certainly those are some of the challenges to try to figure out how to resolve. So for example, someone makes an investment up front, how do they get the return? Now, I would also make note that, we should probably think about, it's not about just each individual patient, but also thinking about, well, you know what? Yes, a plan makes an investment and the person may be in their plan for this year and then maybe off their plan for next year, but is there some way, but they might be back on in 5 years, right? Mm-hmm. And so there is a bit of like, okay, well, there is some benefit to the general good, but I think the other part though to think about is that how do we, let's put it this way, if someone's doing a really good job and they're actually able to be successful, right, and get a return on that to both reinvest, I think the odds that person will want to stay with that plan unless they completely, unless someone else is getting a lot better at it than they are, is probably pretty high, right? Mm-hmm. And in fact, actually, when you see Kaiser, they actually have people around, even though they're signing up people year for year for a fairly long time. Mm-hmm. So I think the issue, I think that in some ways will, I won't say take care of itself, but I think that that's going to be an opportunity for risk-bearing organizations. Now, you mentioned like, oh, well, does this sound more like a single payer? Now, so I'm in politics, right? And remember I said the healthiest 50% of people only spend 3.5% of the healthcare dollar? So I will say that in health reform, one of the biggest challenges, whether you do it economically through what we're doing now, or quasi-economically, it's not entirely, politically, like let's just move everyone to one government system, is how do you convince people who are healthy to essentially pay for people who are sick? All right? I mean, that's the conundrum, right? So by the way, in order for me to get elected, I don't need 100% of people voting for me. I just need 50% plus one. So if I can keep the healthy people happy, screw the sick people, sorry, I didn't say that. I could still win an election. All right? And in fact, actually, let me put it in more practical terms. So California, actually, we had a high risk pool, right? So people were really sick, we had a high risk pool, all right? It didn't work. We didn't have the political will to adequately fund it. Richard Figueroa is now the acting director of DHS. He used to be a Mr. Mib, and he said people died before they even got, on the waiting list. That was a political issue. Right? Because that ultimately, how much money we're going to put into our, government-funded healthcare, right? Including whether it's single payer, Medi-Cal, or whatever else, is partially a political decision, right? And so, we have lots of different things we can put money into: roads, criminal justice, health, social services. And so the question is that how do we build this essentially social consensus that it's worth investing in people who may be expensive now, but also we need to, that there's benefit to us to get them to be, some of them at least, to get back to the workforce. How do we make those kind of decisions collectively, right? And so I would say that single payer basically makes this a political problem versus a, partially economic one.
Yeah. What about, I mean, it seems like one of the places where there is still a challenge in the healthcare system, there are a lot of places, of course, but this sort of 401% of premium small employer or individual who essentially has no subsidies or very little subsidy in the individual market faces very high deductibles for a plan that is not always meeting their needs in terms of benefits. It seems like those folks they're not left behind per se, but there's still problems in stabilizing that market for higher income, really middle class and higher income earners. What are your thoughts on how to better provide coverage or build policy to support that demographic?
Well, I mean, that's why it said last year, that's what we did, right? We were providing subsidies people were up to 600% of the federal poverty level because we realized that cliff was a problem, right? Particularly if you're in the older trench, right? So if you're in the 50s, and the idea was to try to work to make essentially health insurance coverage more affordable. Now, affordable, there's a lot of different ways people can look at it, but essentially, we're trying to say that we're going to provide you some help, so it's still going to be a big chunk of your income, but it's it's something that hopefully is manageable, right? And so that's paired with a requirement to get health insurance, or you do pay a penalty for not having it. Because ultimately, the challenge is that when someone gets ill, we do all eventually pay for it. So when Schwarzenegger was trying to do his health insurance, people figured out that for all of us who had private insurance, we essentially were spending $1,000 a piece to pay for the people who couldn't pay for their health care coverage, but are pay for their health care, because when they came into the hospital or wherever, those costs don't just vanish, they have to get distributed to everyone else. So by getting more people into coverage, actually, you can better align, instead of trying to do all these cross subsidies to cover those gaps, you better align the fact that, okay, well, this person is covered, so therefore the money's coming from here, and then you can start thinking about what's more effective use of those funds, right? Is it more effective use to have people wait until they're really sick and then land in the ER and then get admitted to the hospital, or because now they have coverage, they can actually see a physician or do other things that might prevent that from happening.
How do you, I listen to you, sometimes I hear you talk as a policy guy, and sometimes I hear you talk as a budget guy. Obviously, you're both. The budget piece must be a little complicated as a caucus member, with a caucus that has some folks who are very adamant about, a more progressive healthcare system in their view, or progressive policy. There's a lot of money, or there's a super lot of money, depending on their view of the current situation. That will change at some point. What are the dynamics within the caucus on this issue for folks who want to run for higher office or folks that want to be more progressive in terms of policy and say there's a lot of money, if we don't do it now, when would we? And the people have spoken through a number of mechanisms, and they come to you as one of the chief budget writers on this topic, and you're like, how are we going to afford it? What is that caucus dynamic like?
Well, first of all, I would say is that what we want to do is we want to make most effective use of the money we have, right? I mean, I hope we can all agree on that. We want to think about, and so one of the things that I do as budget sub-chair is always challenge the Legislative Analyst's Office and the Department of Finance and said, okay, if we don't do this, what's the cost? And if we do this, what's the cost? So let's take, for example, Medi-Cal previously was not funding the diabetes prevention program. That was not a covered benefit. Diabetes prevention program reduces the progression of people who are pre-diabetic to diabetic by roughly about almost half. All right, and we also know that almost half of all Californians are pre-diabetic. And in fact, if you saw the recent news, they said teenagers 1 in 4, something like that. And so when someone actually progresses from pre-diabetes to diabetes,
that costs a lot of money, because when you're diabetic, you're talking about insulin, you're talking about test strips, you're talking about dietary, lots of other things. So then the question was is that you can score and say, well, look, if we provide coverage for diabetes prevention program, a evidence-based, and there's good evidence-based for that do you score simply say, well, look, that program's going to cost money. We're going to have to see, we're going to have dietitians go and work with these patients, et cetera. And so do we just simply score that as a cost, and then we say, well, can we afford it or not? Or do we say, well, let's also look at what happens if we don't do that? And what's the cost of not doing anything, right? And I think that's what we need to try to look at. It's not that easy, and I think one of the things I say is, there are a lot of people who make claims. We need to demand evidence, and sometimes there's no evidence to work with, right? Someone hasn't done the research that we don't know. But we should try to certainly do our best based on the evidence we do have to try to make the most effective use of the funds that we have. And so, certainly one of the things that we've certainly been working on is recognizing that the more people we have in terms of healthcare coverage, generally, so far we've seen the results showing that we do better in terms of, being able to make effective use of those funds. Yeah. And so I think that that's something that we certainly want to try to look through that lens.
You mentioned evidence. The island nation of Samoa has about 200,000 people.
Yes.
They have, in the last 12 days, 13 days, identified about 3,800 cases of measles that have broken out. About 58 people, mostly children, have died. And
all unvaccinated, by the way.
All unvaccinated.
That's what the Prime Minister said, all unvaccinated.
To the point where the government has launched the mass vaccination campaign that's now vaccinated 60,000 people. Government is shutting down entirely because it can't handle anything else. So on the 5th and 6th, the government announced today that they would stop functioning as a result of this outbreak, and then only focus on vaccinations. That was a topic of conversation, has been a topic of conversation, vaccinations and personal exemptions and other exemptions. Yes. With legislation that would limit and narrow the potential exemptions for kids that would go to public schools. How has that issue been in terms of working it when people have, strongly held beliefs, and yet we are removed from a mass epidemic like Samoa is going through here in the United States, but could be around the corner?
Right. Well, the situation in Samoa is extremely tragic. Actually, if you look at the other island nations around it, they have vaccination rates around 90%. So, by the way, Samoa, American Samoa, which is actually separate, they're not having outbreaks of measles, right? And what happened in Samoa, they had a vaccination rate around 30%. Okay, and what had happened there is that unfortunately they were previously a few years ago at 80%. There was a tragic. I don't know, accident's not the right word. Basically, 2 nurses mixed some of the vaccines with actually anesthetics, right? So if you take an MMR, you're supposed to mix it with saline, and then you do it. Well, they mixed it with anesthetics instead of saline, and of course that killed a couple children because the anesthetics killed the kids. And then until they figured it out, the government suspended vaccinations, and then unfortunately, anti-vaxxers claimed it was the vaccine itself that killed the children, and then, of course, fear-mongered that, drove the vaccination rate now. And so certainly it's tremendously tragic that 2 children died of that, and those nurses, by the way, have been convicted. I believe they're in jail for killing those kids, right? But because they fear-mongered by the way, the same people who are out there protesting, if you go outside, because I'm here, they basically then blamed it on the vaccines, fear-mongered the parents into not getting the kids vaccinated, and now we have, as you said, over 50. It's 58 now. I'm trying to remember.
Yeah.
58. By the way, almost all of them are children.
Yeah.
Who have died as a result of this measles outbreak. Many others, their hospitals are completely overwhelmed, and I think that. So one of the interesting things about doing SB 276 and then previously 277, the vaccination bills, is really about the importance of coming to agreement around the science and the facts, right? I mean, as I think Senator Daniel Moynihan said, you have a right to your own opinion, but not to your own facts, right? The facts are the facts, okay? And when we have policy that's unmoored from facts, we create situations that become dangerous, like unfortunately what's happened in Samoa. I will point out that in 2015 we had the measles outbreak here that started in Disneyland, right? It spread over 130 some people got infected in California. It spread across the country. At least 20 people got hospitalized, right? And then we took action. We passed SB 277. This past year, we've had more cases of measles in the country since 1992, over 1,000 cases. By the way, there are at least two identified cases of people bringing measles to Disneyland this year, okay? But did we have another outbreak as large as we had in 2015? No, we didn't have a 100-person outbreak. We had some smaller ones, and found out, UCLA and Cal State LA had to, they quarantined a bunch of people to try to, prevent outbreaks. But we didn't have another large outbreak. That's because we took action.
Yeah.
We took action. And then 276 was because what happens is we saw that we were drifting down again because unfortunately a handful of unscrupulous physicians were selling medical exemptions, profiting, and then in the process making us vulnerable again.
It's always the doctors, isn't it?
Well,
just kidding.
There you go.
Just
so, there's always a few bad apples in every group, unfortunately. Yeah. So the thing is, we need to protect the public, right? It's about public safety, and that's why we passed those laws. I've told the opposition that if we stop having outbreaks, I'll stop authoring more vaccination laws, right? That's because outbreaks aren't good. You can, let's look at what's happening in Samoa. Think about what's happened in in Europe. Europe's had thousands of cases. I think at least in the past few years, over 80 people have died over the past few years. Samoa, just in the past several months, we've had 50 people die. These are serious diseases. And so when they go around saying the diseases aren't serious and vaccines are poison, that's not true. And yeah.
I want to give you all an opportunity to ask questions here in just a second, so get your thinking caps on if you have some. And I'm going to call on Nick at the county if nobody raises their hand. But what is it? I mean, I think being a public servant, an elected official, means you got to know why you're getting out of bed. Because it's hard. And you got to take a lot of slings and arrows, and one day you'll be Mr. Popular, and the next day you'll be Satan, right?
Or both at the same time.
Yeah, right. So you get whipsawed. What has it been like at this point in your political career to be physically assaulted, to have experienced something like the attack on the Senate floor from the gallery, not on you personally, but on the institution, and to be harassed and I'm sure threatened? As you haven't told me you've received death threats. I am sure you've received death threats.
I get them regularly in social media.
Yeah. Well, that must suck. What's that like?
Well, it's not fun. But I also point out for all the people who are, well, let's put it this way. For all the people who are, and there's not actually that many of them who are making all this noise, there's so many other people out there who are have been so supportive. And more importantly, I know that we're saving the lives of people, right? I mean, that's why bother being in office if that's not what you're going to do, right? Mm-hmm. So I think that the reason I ran for, I'm a pediatrician. I don't need to be a legislator, right? In fact, I wasn't planning on running for public office. I only ran during the Great Recession because I was so frustrated about some of the gridlock that was happening. We couldn't pass a budget on time and so forth, and said, okay, well, we'll try to see what we can try to do to move the needle for doing that, and that's what we're trying to do. So, I think having, again, the good thing about politics is and I appreciate that we have a lot of great colleagues on both sides of the aisle, and we actually, and we should have passionate dialogue and debate and about how to make our state better, right? And we may have different ideas about doing that, and that's fine. Okay, we need that, all right? People have different ideas, people do so forth. People bring in more information, knowledge about what's going on. That's what we should be having. What we shouldn't be doing is saying that the way we make policy is to go and bully and attack, physically even, try to stop the democratic process. The people who, the same people who threw the blood onto the Senate floor, which by the way then forced us to move into another room, also were screaming at on the assembly, trying to stop the assembly from being able to conduct their business by screaming from the galleries, chanting, standing on chairs in the assembly and the appropriations committee. I mean, those types of. That's not about getting your point across. That's simply trying to stop the democratic process. And so certainly I think people have, we should always fight passionately for people's First Amendment rights. But I think, as I say, the right to speak shouldn't silence someone else's right to speak as well. And I think that, and sometimes what they're trying to do is they're trying to silence the rest of us who are trying to do the work that needs to get done.
Questions from you all here in the audience? We have one over here, unless, Luke, you want to grab?
I just want to thank you for your leadership on SB 277 and let you know that the organized medical groups and IPAs across California focused on pediatric vaccinations over the last 2 years. IHA just reported to us, and it's recognized on the Office of the Patient Advocate's website, pediatric vaccinations have increased by 14% in the last 2 years in California. I think this is due to your leadership on SB 277, so thank you.
Thank you.
Okay.
Thank you. Thank you.
I will say, for what it's worth, he didn't identify himself, but Bill Barcelona is the Executive Vice President at America's Physicians Groups and one of the people I respect pretty much more than anybody in Sacramento, or as much as anybody, certainly. So, other questions here?
Good afternoon. My name is Jackie Mark. I'm here from CalOptima, which is Orange County's Medi-Cal, for those who didn't know. You talk a lot about value-based payment, which is a really great program, but you also talk about that these physicians are going to have to change their practice. Currently, the value-based payments are only funded for 2 years, pending our state's financial stability. So how can we then incentivize providers to use value-based payments without longevity?
Well, you make an excellent point. And this is the tension we have between the sort of the political process and trying to get change, right? So, so I'm the state budget, right, the budget subcommittee chair, and like, okay, well, we don't want to make long-term commitments because we don't know what the future holds, right? We know our income stream is very volatile. Of course, anything to deal with Medi-Cal also has to go through CMS, so sometimes CMS isn't so interested in, they're like, okay, let's try to pilot it. And then at the same time, you go, and I'm a pediatrician of Medi-Cal, right? It takes care of Medi-Cal patients. Oh, by the way, we have this program, and we want you to change the way we do things, and I'll promise you I'll pay you for 2 years. Oh, by the way, actually, we'll start paying you for the change a year later, and then we'll backfill it, and then we'll pay you for 1 more year, and then I don't know what will happen after that. So I definitely hear what you're saying. I definitely understand. I think that's something we need to work on. I would say that certainly from where I sit, of course I have term limits too, is that I want to be sure we make this sustainable. So that is something we're going to have to work with the physician, other provider community around, and think about what we can try to do to build that level of confidence. But I certainly understand that's a big challenge, right? Because we can only promise them we're going to do it for 2 years for now, and then we'll say, well, we think that after it's over, we'll keep doing it, right? And that's not always the most compelling message to go forth. But certainly I'm committed to trying to make value-based payment work both within Medi-Cal, but also trying to figure out how we do it more broadly too, because we need to try to get enough payers aligned so that it makes sense for a provider to say, okay, I am going to make those fundamental changes I need to make in my practice because it affects enough of my patients, right? It's not a one-off or one program. It's something that I see coming across, and I think that's part of the conversation we also need to have with sort of the other payers too, in terms of their willingness to commit to a longer-term approach.
Great. Another question?
I'm Gary Rotto with Borrego Health, which is the largest community health center in the state. I'm also on the staff faculty at San Diego State School of Public Health.
Oh, excellent.
So I wanted to first thank you for your ongoing support of community health centers. You work at one on Friday afternoons, still seeing pediatric patients. Appreciate that. How you're continuing to do both your political work and continuing to practice health is amazing. And also appreciate the great work that your health committee staff does and the opportunity to work with them, especially with Kim on a regular basis. So my question has to do with the governor's executive order, with the carve out of the prescription drug benefit from managed care to fee-for-service, and the effect on the 340B program and the services that community health centers can supply for the patients that would not have any other source to be able to provide those services, which have so much to do with patient compliance, outcomes, and quality. Sure. What do you see as the potential future for continuing that any source of funding that can support those types of programs and services?
So certainly, it's an ongoing conversation with the administration. I think the legislature has made it clear we don't want the 340B program to simply vanish, or that that those types of funds simply vanish. What the administration pushes back on is they say is that, well, some of the way the funding works is that it goes into, there's, as they say, there's not enough accountability, right? So we hear, and you know what, I have confidence that you and most of the people doing 340B, that money is going to help pay for good things that unfortunately Medi-Cal isn't paying for right now, right? And so you can use those funds to do those kind of things. The administration does come back and say, well, that's great, you take it on faith, but we'd like to see more accountability around that. I think that it's going to be, we're continuing to push on the administration. One of the things that we might be talking about, though, is saying, okay, fine, well, where do we land in the middle? One of it is to say there is going to need to be some way of counting for, okay, where those funds go. And so if, for example, under the single purchasing thing, and you lose some of that 340B subsidy money, that we backfill it with other Medi-Cal money, but then you have to account for where it's being, how it's being spent, right? And so that's going to be an ongoing conversation. Certainly welcome the participation and the advocacy by the community health centers, as well as the hospitals and other groups as well, in trying to create a solution that's going to work. But certainly I recognize, and I know my colleagues in the legislature, how important those funds are from 340B in being sure that community health centers, hospitals, and other providers are able to provide the full range of services the patients need, and that we need to be sure that that's protected.
Other questions? No? Since it's just you and me and the beers here on the bar, how would you grade Governor Newsom's first legislative session?
Well, I think the governor is certainly setting a different tone than Governor Brown. I think that one of the things I'm looking forward to is him filling out his healthcare team. So he's almost a year into office. At least we don't have a DHCS director. We do now have a new director of public health. We have a secretary of health and human services. So they're filling it in. And and there's also a lot of, and it's not necessarily a bad thing, he has a lot of groups coming together, task forces or master plans, right? Master plan on aging, master plan on early childhood, so forth, right? And so there's supposed to be a group to actually look at single payer, which I'm technically supposed to be an ex officio on, but it hasn't met yet. But I understand that's sort of trundling along. So I think part of it's going to be what finally starts coming out of all these master plans. So actually, good. I want to touch on aging. So one of the bills I authored this last year is to look at trying to do an actual analysis to think about financial options for the middle class around long-term care. So oftentimes when we talk about health reform, we don't spend a lot of time talking about long-term care. Medi-Cal, that's one of the big expenses. I actually did a hearing, and the reason I did this hearing around looking at where are long-term care costs going was because at the budget hearing, when I asked the Department of Aging and Department of Finance, so by the way, how far out are you looking about demographic changes related to aging? And they basically said, well, we're just doing it year by year. And I went, okay, that's not very good. And when we had a hearing on this issue, and basically what came out of that hearing is that assuming that we provide the same level of service, there's IHSS, nursing homes, et cetera, at the same level of service, if we weren't going to cut back on that, but just maintain the same level of service, the demographic change in terms of the aging of the population in California would require that we increase funding for essentially nursing homes and IHSS, roughly, on average, 5% per year every year. That's faster than the state GDP growth, and we're one of the biggest economies in the world. That's faster than our budget grows. So even though we're in a really good year right now, we've had a whole series of really good years. If we don't figure out that conundrum, so we talk about like, well, where's money? Right? So I said we want to make the most effective use of our money, but we have a demographic, the silver tsunami issue for the state budget. So we can talk about expanding healthcare and all this other stuff, but we have this issue around how we're going to handle long-term care, because right now the only solution we have to tell people is that, well, spend down to poverty and then sign on to Medi-Cal. We don't have a well-functioning long-term care insurance system here, right? People are aging. We know we're underfunding people with disabilities. That's both young and old. We have a big demographic issue we have to deal with, and so I appreciate the governor taking leadership in his State of the State address. He didn't say anything in his inauguration, but he said in the State of the State address, and so I'm looking forward to working with the governor on that. But that's actually a big thing in healthcare that we often don't talk about. That's sitting out there.
Aging, yeah. I'm reminded as a policy geek, and we have another few policy geeks in the room. Obviously, sometimes politicians speak in sound bites. Sometimes they are a little more long-winded and they speak in talking points. Dr. Pan speaks in white papers. You will not find, I think, a more well-read, more well-researched, and more well-informed legislator in probably any state. So, Dr. Pan, thank you very much for joining us.
Thank you. Thank you very much. Thank you.
Thank you, sir. I appreciate it.
Thank you.